Good morning or good afternoon to folks who are just coming in. We'll be starting right at the top of the hour in about 2 minutes. And just another note for folks who are coming in right now, we're starting in about 30 seconds today's webinar. So go ahead and settle in and we'll begin in just a few moments. Okay, hi everybody, it's the top of the hour, so we're going to go ahead and get started. Welcome to today's webinar, Behavioral Health Lens on Sleep, Assessment and Intervention, part of our year-long series addressing sleep within an integrated health framework. Next slide, please. My name is Andrew Phillip. I'm the Senior Director for Clinical and Population Health here at the Primary Care Development Corporation in New York City. Next slide. If this is your first time joining us, PCDC is a national nonprofit with offices in New York and California. We're focused on advocacy, on practice transformation and investment to really catalyze excellence, and focused on health equity in primary care at a very broad level, including behavioral health and other related aspects that are really at the core entry point for care for most people in the country. Next slide. Just a quick disclaimer. Today's views are that of ours and the presenters, and not of SAMHSA or anyone else in federal government, including CMHS, HHS, or any others. Next slide. Okay. So again, this is part of a broader series. Our focus is on the integration, or the space where we see an intersection between physical health and behavioral health needs, and sleep is right at that core intersection. So we're really using today's session to build a toolbox to develop skills in that areas and look at the roles of different members of the care team in working together to holistically meet the needs of our patients. Next slide. So this is, again, part of our 6-part series. We're actually in number 3 right now on behavioral health. Our next session will focus on the experience of people with lived experience in sleep. And this will be followed later in April by a session on physical health intervention, so looking at medications and medical assessment and intervention for sleep. And then at the end of this year, we invite you to join us for a session on us as healthcare providers and meeting our own needs around sleep. So you can actually find these recordings as well as today's recording and future registrations at pcdc.org/sleep, link there at the bottom of your screen. Next slide. So we'd like to learn a little bit more about you today and who's in the room. So we're going to pull up a slide here. You can let us know, what setting do you work in? Are you in more of a traditional behavioral health setting, a primary care specialty, or a general primary care setting, more of an integrated combined setting? Or if you're in none of those, we're especially interested in hearing where you may be. So let us know. And you have a chat box there in the bottom of your screen. So you can just go ahead and actually select reply all or respond to all so that we can all see. But we'd love to know, what setting do you work in? And then you also have an item there on your screen asking about your professional role. So if you're a physician, a nurse practitioner, social worker, psychologist, others. And again, similarly, if you don't fit into one of these categories, I'd love to see what you do and what your background is. And we see, looks like folks are already chatting in here. Let's see, we've got folks from around the country: early childhood education, occupational therapist, primary care association, excellent. Therapy practice, health promotion, higher education. We've got folks who work with survivors of violence, behavioral health, managed care organizations, great. So we're seeing also nonprofits. We've got payers, we've got direct service providers, wellness coaches, and we can bring up the results of the poll as I'll continue kind of reading these off. We've got folks who are working in homeless shelters, state level policy, city government, probation officer, criminal justice system, HIV case management, state departments of health. So really excellent to see this kind of broad representation. So keep chiming in here in the chat, letting us know where you're calling in from and what your background is. We've got nursing homes, also excellent to see this kind of broadness. You'll see on your screen here, we've got a pretty good spread. So about 72% of folks are coming from a more predominantly behavioral health setting, followed by about 34% of you in a truly integrated care setting, which is great to see. And actually we're seeing that, I think, increasing each session, which is really nice. And then nicely also to see about 14% of folks in a primary care setting. As far as your kind of specialty or your background areas professionally, similarly, kind of a nice mix between therapists and then largely others. And I think that's well reflected here in the chat. We're also seeing care navigators, clinical psychologists, social workers, supervisors, prevention specialists, community health specialists, school wellness centers, excellent. So really nice to see, again, keep them coming in. And again, this diversity in terms of professional roles and also settings, I think really speaks to the broad interests around sleep and sleep health, as well as this, again, this kind of critical interface between our physical health and our behavioral health needs. And so we'll continue speaking to that over this series. And again, today, we're really going to be focused on the behavioral health and behavioral health assessment and intervention for sleep. Over these past few months in the series and in our discussions together, there have probably been more questions around this topic than just about anything else. Questions that you've been posing have been around what types of questions do you ask to kind of learn about sleep needs in the course of whether it's a behavioral health visit or a specialty care visit or primary care visit. So what do we ask? How do we ask it? And then what are the actual recommendations that we can make to our clients and to our patients that actually result in some sort of tangible improvement in the quality of their sleep, but that also then touches other aspects of their health, from mood to medical conditions, chronic diseases, and others. And we've talked this year about how those all interplay. And also, as we heard in our last session, how these are all impacted by health, or health equity rather, by social determinants of health, by who we are and where we come from. And so our sort of levels of complexity are increasing. And so here we are today, and I'm excited to introduce our speakers who will be talking about this more specifically on behavioral assessment and intervention strategies. So first I'll introduce Dr. Anayansi Lombardero. She's an assistant professor at the University of Nevada, Reno School of Medicine, Department of Psychiatry and Behavioral Sciences. She earned her PhD in clinical psychology from the University of Montana, Missoula. Dr. Lombardero completed a fellowship in clinical health psychology at the New Mexico VA healthcare system, where she specialized in integrated care and health promotion and disease prevention. Her research centered around management of chronic diseases and around testing, implementation, and best medical education approaches, specifically related to behavioral change for at-risk populations. And she's worked with many different populations, including different ethnic minority groups, US military veterans, patients with multiple complex medical and psychiatric comorbidities. And she has clinical specialties in brief evidence-based interventions for insomnia, also smoking, depression, anxiety, PTSD, and others. And she's also been core faculty in the clinical and community psychology program at University of Alaska Anchorage prior to moving to Nevada. And her current work at UNR Medicine consists of evaluating cognitive behavioral therapy for insomnia, residency training in psychiatry, and her research group is currently conducting research and literature reviews, including summarizing the findings of the effectiveness of Cbti, or cognitive behavioral therapy for insomnia, among menopausal women. So fascinating. She's also bilingual in English and Spanish. And our second presenter, I'm particularly pleased to introduce because he may be familiar to many of you, Lee Ruszczyk. So Lee is the Director of Behavioral Health at Henry J. Austin Health Center and has an extensive background in history working directly with both mental health and substance use disorder seeking populations in nonprofit and private practice settings. He taught undergraduate addictions courses as an adjunct professor and mentored social work students. Lee's been a licensed clinical social worker for the past 30 years and has worked with underserved populations throughout his career. In his spare time, he enjoys reading, riding his motorcycle, and photography. And so you may remember Lee from being one of our guest panelists if you joined us for our pre-session panel on needs for FQHCs, or Federally Qualified Health Centers, and sleep. So without further ado, I will turn it over to our guest presenters today, starting with Dr. Lombardero.
Hi, everyone. It's a pleasure to be here. I'm really happy that I was invited to present on cognitive behavioral therapy for insomnia. And I am hoping that this presentation provides you with some information about the behavioral conceptualization of insomnia and the treatment components in Cbti. And I also want to make sure that we're providing you with enough tools and that we're here to answer any questions that you may have. So I look forward to the more interactive portion of this webinar. Again, thank you for inviting me, and I'm excited to present. So if we can go over to the next slide, please. So I thought I'd start by talking about the key objectives in terms of what we're hoping to accomplish here. So first and foremost, I want to explain how we conceptualize insomnia from a behavioral perspective, because this is the foundation and rationale for the treatment that we're going to talk about today, which is cognitive behavioral therapy for insomnia. I also wanted to provide you all with information about clinical practice guidelines in terms of the assessment of insomnia, and to provide you with some assessment tools that you can use in your practice. And lastly, of course, I want to talk about cognitive behavioral therapy for insomnia, what it is, what it isn't, and the various components of Cbti. So I'll be referring to cognitive behavioral therapy for insomnia as Cbti. So next slide, please. Some of the takeaways from today's session that I'm hoping we'll achieve is that Cbti is highly effective for patients engaging in problematic sleep behaviors and thoughts. There is a lot of research highlighting the efficacy and effectiveness of Cbti, and I won't go into the research today because I want this to be more of a practical presentation. But I do want you to know that there is so much research now highlighting the effectiveness of Cbti that it is the recommended first line of treatment for insomnia by the American Academy of Sleep Medicine and by the American College of Physicians. We do know that between 70 to 80% of patients who go through Cbti benefit from it. About 50% achieve clinically meaningful outcomes, and about a third become good sleepers. There's cross-discipline consensus too, and that the American Psychological Association now recognizes Cbti as a well-established treatment for insomnia. It should be recommended before sleep medications. So even if you don't do Cbti in terms of its manualized form, because you're in a primary care setting or because your patient may not need it, you can use some of the principles of Cbti with your patient population. And you can suggest further treatment to those who are engaging in maladaptive behaviors or cognitions that contribute to insomnia disorder. If you would like to have more information, definitely go to the Society of Behavioral Sleep Medicine or the American Academy of Sleep Medicine. And there is, of course, up-to-date information in terms of the research on sleep and insomnia. Next slide, please. So before we get into the bulk of our presentation, we have a case study presented by Lee Ruszczyk. So I'll hand it over to you, Lee.
Thank you. Next slide, please. So what we thought we would do is we would provide you with a clinical study in order to consider, as Dr. Lombardero speaks, how you might apply it to this client. As Andrew said, I work in an FQHC, which is a federally qualified health center. We practice integrated care, and I am in an urban setting. So this patient that I'm going to discuss is a typical patient that we would work with that would come into our center. So the patient is a 46-year-old African-American female. She came into the center reporting that she is having difficulty sleeping. Her request was for medication, and she's identified that she's had those difficulties for the past 2 years. And according to her, she's defining her sleep issues as having a very difficult time falling asleep. And she's really having once she does fall asleep, she's having a very difficult time staying asleep. As part of our practice at Henry J. Austin, we do, if you've heard me speak before, what we call a wellness screen, which involves the PHQ-2, the GAD-2, the ISI or Insomnia Severity Index, and a question from the NIAAA and NIDA. So in the application of the ISI, the patient scored an 8, stating that she is up most of the night on an almost daily basis. And she is also denying that she doesn't have any periods of time during the day that she sleeps. She may grab a quick half-hour nap here or there, but nothing extensive. She describes her sleep environment as comfortable, so she feels she has a safe and quiet place to go to sleep. And she's also denying any use of any caffeine. Next slide, please. She's the primary caretaker for her grandchildren during the day. She does have a history of taking medication for her sleep, and she came into the center being prescribed hydroxyzine. She's reporting it as being ineffective. She is requesting Ambien from the primary care provider. In addition to the described previous sleep issues, she's also reporting that at times she does have nightmares where she is startled and jumps up awake out of her bed. No details on exactly what's driving these nightmares at this time. Physically, the patient has a history of back pain, hyperlipidemia, and on the wellness screen, she also was positive. She scored positive on the GAD-2, which is anxiety, and the PHQ-2 for depression. So that is our patient that we will be thinking about as Dr. Lombardero presents Cbti. Next slide.
Thank you. I really like these case studies and look forward to talking more about it because they bring the information to life and they make what we're talking about more relevant. So before we get into Cbti and what it is, I wanted to talk a little bit about insomnia. There are a lot of misconceptions about insomnia and sleep, and I wanted to go over what insomnia is and what it isn't. So insomnia is not simply sleeping too little. So for example, there are people who may have insufficient sleep that's due to just lack of prioritizing sleep. I know that sometimes people will say, well, I'll sleep when I'm dead, and they may get 4 hours of sleep by choice. That is not insomnia. So according to the Diagnostic and Statistical Manual of Mental Disorders, in order for a person to meet diagnostic criteria for insomnia, they have to have a predominant complaint of dissatisfaction with sleep quantity, quality, and that it has to be associated with one or more of the following. So it could be difficulty initiating sleep, difficulty maintaining sleep, or early morning awakenings with an inability to return to sleep. Oftentimes we see both difficulty falling asleep, difficulty staying asleep, and we may have all three of them as well. This has to cause clinically significant distress or impairment. So if the person is coming in because they're distressed because of their inability to fall asleep or their difficulty with sleep, then you may be looking at whether this person meets full diagnostic criteria for insomnia. Next slide, please. Next slide, please. Okay, the sleep difficulty has to occur at least 3 times per week. We have to have that consistency. It has to be present for at least 3 months. If it's less than 3 months, then it's acute insomnia. This difficulty with sleeping has to occur despite adequate opportunity for sleep. So again, like I mentioned, if someone is not providing themselves with the opportunity to sleep, then it's not insomnia. And people with insomnia, we see that they provide themselves with plenty of opportunity to sleep. They may go to bed really early and stay in bed for a long period of time in an effort to make sure that they're getting enough sleep. But that effort actually doesn't work out for most people with insomnia. It can't be better explained by another sleep disorder, so we have to rule out other sleep disorders. It can't be attributable to a physiological effect of a substance, and the predominant complaint cannot be adequately explained by a coexisting mental or physical conditions. So next slide, please. In terms of differential diagnosis, we want to make sure that we're not diagnosing someone with chronic insomnia if they're just maybe different in terms of their sleep. They may get 6 hours of sleep and they may be okay with that, or if it's within the normal sleep variations, then we're okay. There's also a situational or acute insomnia, meaning that the person with the insomnia is going through maybe an acute stressor, and this is what's accounting for their difficulty sleeping. There's also delayed sleep phase and shift work types of circadian rhythm sleep-wake disorder, so it can't be one of those, although we do have behavioral treatments for those too. Of course, you also want to rule out narcolepsy, parasomnia, sleepwalking, etc. Those are less common, but you do want to rule them out. And you want to rule out a substance or medication-induced sleep disorder of the insomnia type. Next slide, please. Okay, so let's say that you've met with your person and you think that they meet diagnostic criteria for insomnia, and you want to explain to them what Cbti is. Essentially, what you would say to them is that Cbti is a cognitive behavioral therapy for insomnia. What this means is that it addresses cognitions that interfere with healthy sleep. It also addresses behaviors that can maintain the insomnia. So many people are familiar with Cbti. Cbti is just a multi-component treatment for insomnia that addresses, again, maladaptive cognitions and behaviors that interfere with insomnia. And we'll talk about the different components. But I do want to highlight that Cbti is not the same as sleep hygiene. So a lot of people think that if they're doing sleep hygiene, that's Cbti, or that if they're referring someone to Cbti, that they will talk about sleep hygiene. This is not the case. You'll see the many components of Cbti. Sleep hygiene is only one of them, and sleep hygiene alone is not an evidence-based treatment for true insomnia. So next slide, please. Another question that people often have is insomnia a symptom or is it a disorder in itself? We know that if we have people coming in with depression, for example, they may complain of difficulty falling asleep or staying asleep. So are we diagnosing them with depression or insomnia or both? So again, to highlight that disturbed sleep is a symptom if it's because of a mental disorder. So if the person is having difficulty sleeping because of their depression, it would be a symptom of depression. If they're having difficulty sleeping because of underlying stress or a medical disorder or substances, then it is a symptom and not a disorder. Disturbed sleep is an insomnia disorder if it's associated with distress or impairment that is perceived as being due to the lack of sleep, to the poor sleep. So they're coming in saying that, and in fact, I had a patient tell me this recently, again, complex psychiatric picture, but the person said to me, if I could just sleep, I know that I would benefit from just a good night's sleep, and I know that my depression would improve. And his main source of distress was that he was not sleeping well at night. So then this person would meet criteria, of course, for major depressive disorder, but also insomnia disorder. Next slide, please. I wanted to give you this article as a reference because it is very good. It's the clinical guideline for the evaluation and management for chronic insomnia in adults. It gives specific and detailed recommendations in terms of how to address insomnia, how to assess for insomnia, which is one of the goals of today's talk, and we want to make sure that we're doing that. So if you read over this article, we'll give you most of the information that you need to make sure that you're following clinical practice guidelines. Next slide, please. So this is from that article from the American Academy of Sleep Medicine. In terms of guidelines for the assessment of insomnia, they do recommend that at a minimum, you do a general medical or psychiatric questionnaire to identify comorbid disorders. For those of you working in primary care settings, you probably do screening questionnaires already. I know that when I was doing my postdoctoral fellowship at the VA, we did have screening measures that included the PHQ-9, the GAD-7, the PC-PTSD. So we have enough screening measures that you can use, that you're probably already using, that can help you with this option, this part of the assessment. There are other assessments. So there's a sleep log that I'm going to show you that can give you a fairly accurate representation of what the person's sleep looks like, how long they're staying awake in the middle of the night, whether they're suffering from a delayed sleep onset, and you'll get very specific information about that. There are additional assessments in terms of subjective sleep quality, daytime function. You want to know if they're engaging in dysfunctional beliefs and attitudes, and I provided you the names of those assessments, and you can also find them in the article that I just mentioned. So next slide, please. In terms of the goals of CBTI and the treatment outcomes, we do want to make sure that we talk to our patients about what their treatment goals will look like, what it will look like for them to go through this treatment, and to help them have realistic expectations in terms of what CBTI can and cannot do. So we may not be able to get someone who's currently sleeping 5 hours a night to suddenly sleep 8 or 9 hours per night. But we do have some outcome indicators that include wakefulness after sleep onset latency. So we have reductions in sleep onset latency, or how long it takes someone to fall asleep. We would want to see a reduction in terms of the number of awakenings. The sleep efficiency, we want to make sure that we're keeping track of that throughout the treatment and at the end of treatment. And sleep efficiency essentially refers to how much of the time that they're spending in bed they're actually spending sleeping versus just tossing and turning. And then we also expect to see improvements in terms of sleep-related psychological distress, daytime functioning, and so on. Next slide, please. Okay, so I also wanted to say that in terms of assessment, you want to make sure that you get an adequate sleep history. And if you have a treatment manual, it can walk you through that process. But the article that I just mentioned also has information in terms of what kinds of questions to ask. And so for those of you doing psychiatric assessments or even medical assessments, it's fairly similar to what you do already, in that you're asking questions that will characterize the complaints. Are they having difficulty falling asleep? Are they having difficulty staying asleep? How many awakenings are they having? What's the onset, duration, frequency, severity, and course of the insomnia? Are there any perpetuating factors, and we'll talk about what those are, that may be contributing to the maintenance of the insomnia? And also, have they had any treatment for insomnia in the past, and what was their response to that? We want to ask them also, what kinds of activities are they engaging in just prior to bedtime? What's their bedroom environment like? Are they sleeping in a bedroom that's dark, that's cool, that's quiet, or are there problems with that need to be addressed? What's their mental state at night? Are they feeling very anxious, restless? Are they just really stressed? If they are, then that might be a clue that they can benefit from relaxation strategies prior to going to bed. Of course, you want to get an assessment of their sleep-wake schedule. So what's their bedtime? And you'll get this through the sleep diary, but you can also ask during the initial evaluation, how long does it take them to fall asleep? Why is it taking them such a long time to fall asleep? What helps, what doesn't help? How many awakenings are they having at night? And what are they doing during those times that they're awake? Are they tossing and turning? Are they getting out of bed, etc.? And then you want to know about their final awakening, and also not just their final awakening, but what time are they getting out of bed? So if their final awakening is at 5, but they're getting out of bed at 8, that's something that we want to keep in mind too. You want to ask about possible symptoms of obstructive sleep apnea, restless leg syndrome, and other possible diagnoses. And then lastly, you also want to ask them how they're feeling during the day. Are they feeling fatigued? Are they having any daytime sleepiness? Are they engaging in napping? What's their lifestyle like? Are they traveling? And then what are their consequences of their difficulty sleeping in terms of their mental state or their quality of life? So you can get an assessment of that by simply asking them. So if we have now a patient, let's say that we've gone through all of these questions, a screening questionnaire, and we've done the minimal assessment. Now we're ready to apply the behavioral conceptualization of insomnia. So let's go over what that is. Next slide, please. So the way in which we conceptualize insomnia is by use of the 4P model. So depending on what you read, you might see a 3P model of insomnia by Spielman. And the one that I'm presenting to you here is an updated 4 model explanation of insomnia. So according to this model, I'm going to tell you what the 4 Ps stand for. So we have predisposing factors, precipitating factors, perpetuating factors, and Pavlovian factors. So we'll start here. I can't really point, but we'll start all the way at the left where you see pre-morbid factors. So according to this model, there are some people who are just born with a predisposition to the development of insomnia. So they may have a highly sensitive or a malfunctioning biological sleep system, or they may have a hyperactive arousal system that interferes with sleep. So some people are naturally essentially more anxious than others. And this might predispose them to develop insomnia. Now that alone is not sufficient to cross over the insomnia threshold that you see there. So for acute insomnia, typically what drives the acute insomnia would be a precipitating factor. So precipitating factor would be a stressful experience. So this could be a good example of what that might be that's relevant to today would be COVID-related problems, for example, financial problems or others. It could be a psychiatric condition. It could be any sort of stressful event. Now, for someone without the predisposing factors, once the precipitating factor goes away, we would expect for the insomnia to resolve. But what happens is if someone has this predisposition to be highly anxious or overly sensitive in terms of their biological sleep system, is they might now be overly concerned about sleep, and they may engage in behaviors to attempt to address their sleep problems that actually have the opposite effect. So they may spend extra time in bed in an effort to increase their opportunity for sleep. But what happens is that these efforts in which they engage, rather than help cure the insomnia, actually serve to develop and maintain the insomnia. So these are the perpetuating factors and essentially the main component of Cbti. The last P are the Pavlovian factors. And for those of you who have had an intro to psych class, you probably remember Pavlov, the classical conditioning, the experiment that was done with salivating dogs. So Pavlovian factors refers to classical conditioning, and this is what happens to people with insomnia who are tossing and turning in bed when they're trying to fall asleep. There's this association that's created with the bed as a place in which one lies tossing and turning and with a lot of anxiety, provoking thoughts, and rather than having an association between the bed and something that you use just for sleep. So those are the 4 P's in the evolution of insomnia. And you can see that once the acute precipitating factors have gone away, now what we have is purely the perpetuating factors and Pavlovian factors that are serving to maintain the insomnia. So these are going to be the treatment targets when we do our cognitive behavioral therapy for insomnia. Next slide, please. Okay, so this is just a further explanation of classical conditioning. So here you see that we have our bed, which for most of us, hopefully, it's hard to say during these COVID times, but hopefully we see the bed, we get into bed, and we have a positive association with the bed as a place in which we relax, as a place in which we sleep. However, for people with insomnia, that's not the case. And what happens is they may toss and turn, they may worry in bed about things that they have to do tomorrow or about their inability to fall asleep. And what happens is we have what we call conditioned hyperarousal. So now this association of the bed between with a place where we sleep is no longer there. So now what we have is this association in which we're hyperaroused when we go to bed. And a good indicator of that, if you're interviewing a patient, is you can, if they say, well, I feel really, really sleepy, and then as soon as I go to bed, I find myself wide awake. That's a really good indicator that conditioned hyperarousal has taken place. So next slide, please. And I think we can all, or a lot of us can relate to that. So the next model here in terms of sleep and insomnia is this two-process model of sleep regulation. So as you can see, sleep is regulated by internal mechanisms that we have. Our bodies are very smart. The first one is this homeostatic sleep drive, which is essentially our drive, desire, or need, hunger for sleep, so to speak. I will explain what that is. And then there's also another mechanism that's associated in the sleep regulation that's internal, and that's our circadian clock. And most of you have probably heard of the circadian clock and are familiar with what that is, but you may want to explain it to your patients too. So I'll go over what those are for the next slide, please. Okay, so the first one that we talked about was the sleep drive, the sleep regulation. So this is a homeostatic process by which a sleep deficit results in a compensatory increase in the intensity and duration of sleep. So essentially what this means is that the longer we go without sleep, the higher our sleep drive should be. Adenosine is thought to play a role in sleep homeostasis in that we have accumulations of adenosine throughout the day, so that the longer that we stay awake, the more of it we have, and the sleepier we feel. This is a process that's similar to hunger, for example. So you know that once you've had a meal, you're not very hungry. And then the longer you go without eating, the hungrier you get. So in terms of the sleep regulation process of sleep drive, we have a similar process. So factors that weaken the sleep drive include spending excess time in bed, which we know that a lot of people with insomnia tend to do. Taking naps, just like snacking can interfere with your hunger. If you're taking naps, that will interfere with your sleep drive. Dozing or sleeping in. And again, these are all behaviors in which people engage just to try to make up for the lack of sleep, but they actually weaken the sleep drive. Next slide, please. The second component of the sleep regulation is the circadian clock. And this is just an endogenous internal clock that we have that sends signals to our brain that tell us to stay awake. And that's the reason we don't fall asleep during the day, because we're getting the signals that say it's daytime, stay awake. This clock is not exact. It runs on a 24.2-hour cycle on average, and it relies on environmental cues. So for example, sun exposure to make sure that we're keeping it at a 24-hour cycle. So some of the environmental cues that serve to regulate the internal clock is the timing and amount of light exposure. So in order for us to have a good, well-functioning circadian clock, we want to make sure that we're getting light exposure, waking up at regular times, and that we're getting light exposure at the appropriate time. So we want that ideally early in the morning and not when we're going to bed. And you also want to make sure that there are scheduled activities. So for example, that you're eating your meals at regular times. And that way we can make sure that we're maximizing our circadian clock. Next slide, please. Now, this is just the visual representation of what it looks like to have these two processes together in the sleep regulation process. So up here where it says sleep load, you can see that there are some arrows that go down. That essentially represents our sleep drive. Right? As you can see, when we wake up in the morning, it's really low because we've already replenished our sleep. So, and that sleep drive is going to increase throughout the day until it's at its highest point at around between 9 and 10, depending on the person, but it typically happens at around that time. Now, at the same time, we have the circadian clock that you can see below that's sending signals that tell us to stay awake throughout the day. And it keeps sending signals so that we stay awake throughout the day. And then at around the same time, around between 9 and 10, those signals start to diminish. So in order for us to take advantage of this natural bodily process that tell us to fall asleep. Ideally, we're going to bed right when the sleep drive is at its highest and when those alerting signals from the circadian clock start to lower. You'll naturally feel sleepy at that point, and this is your ideal time to fall asleep. And then you can see that the alerting signals continue to diminish, and that the sleep load continue to diminish throughout the night, and then the process repeats itself the next day, and over again. So let's go over to the next slide, please. Okay, so how do we put all of this together? According to this model, in order for us to have good sleep, we have to have a strong and healthy sleep drive. We have to have a low arousal system. So this is, again, associated with a classical conditioning. So we want to have a strong association between the bed and a place in which we sleep and relax. And we have to have a correct circadian placement. So if we have all of these working properly, we have good sleep. And this is exactly what we attempt to do with cognitive behavioral therapy for insomnia. Next slide, please. Okay, so how do we know if Cbti is indicated? If your patient has chronic insomnia, they tell you that they've had insomnia problems for 3 months or longer, then you can use Cbti. You can still use some of these principles for acute insomnia just to make sure that it doesn't develop into chronic insomnia. But typically people will tell you that if they've had chronic insomnia, that they've had it for months and years. If you are noticing that the person is engaging in behaviors that weaken the sleep drive, so these are the behaviors that we just talked about. So spending excess time in bed, if they're sleeping in, if they're napping or dozing, if they're engaging in behaviors that are interfering with their circadian rhythm. So if they're waking up at 5 one morning, and then the next morning they're waking up at 8 or 9 or 10. Those are problematic behaviors that are going to affect their circadian clock. If they are engaging in incorrect timing in terms of light exposure, or they're not getting enough light exposure in the morning, or not getting enough light exposure at all, then they might have a problem there with their circadian rhythm. And then in terms of hyperarousal, if they are the type of person who tends to worry while they're in bed, they're lying in bed, tossing and turning and thinking about how difficult their next day will be if they don't get enough sleep. And again, like I said, if they feel really sleepy but become wide alert when they get into bed, that's a good indicator that they can benefit from cognitive behavioral therapy for insomnia. So next slide, please. So now that you have the conceptualization of insomnia from a behavioral perspective, we'll go over the components and targets of Cbti. Next slide, please. So cognitive behavioral therapy, as you know, addresses behaviors and cognitions. In this case, in the case of insomnia, of course, there are going to be behaviors and cognitions that are specific to insomnia. Right, so what we want to do with Cbti is we want to make sure that we help our patients engage in behaviors that are going to increase their sleep drive or their desire for sleep. We want to make sure that we optimize the congruence between the circadian clock and the placement of sleep opportunity. Encouraging our patients to go to bed at that time between 9:15 and 10. We want to make sure that we strengthen the signal of the circadian clock. And we do that by again, light exposure, making sure that they're waking up at the same time and going to bed at the same time every day, even on weekends. We want to make sure that we strengthen the bed as a cue for sleep, so that they're only using the bed for sleep and sexual activity and nothing else. So no watching TV or reading or anything else like that. We also want to decrease behaviors that result in physiological arousal, so relaxation strategies can work for this. In terms of cognitions, We address cognitions that interfere with sleep. So we want to make sure that we're reducing sleep effort. So people with insomnia try really hard to fall asleep, and that tends to have the opposite effect of what they intend. In fact, if we ask people if they know any good sleepers, and they said typically people will say yes, and then we ask them how much effort do they put into falling asleep, they'll say none, they just fall asleep. So that's a way to illustrate that the more effort that you put into falling asleep, the less likely it will be that you will fall asleep. So we want to also make sure that we reduce cognitive arousal. So we'll address cognitions that are going to induce anxiety states. We want to make sure that we address dysfunctional beliefs about sleep. So examples of this would be thinking, well, if I don't get 8 hours of sleep, my day is going to be terrible tomorrow. And then we also use the cognitive part of Cbti to address obstacles to adherence. So some people might say, well, this is unrealistic, or I just can't do it. If it's because of an erroneous cognition, we want to make sure that we address those. So an example of that, just to make this clear, would be saying something like, well, no, I'm already having difficulty sleeping, and you're asking me to do these things where I might sleep less. You might want to say, well, you might sleep less now, but in the future, your sleep quality and quantity will be improved. So just getting through, these few weeks of maybe sleeping a little bit less will actually be beneficial in the long term. Next slide, please. So the components of Cbti include sleep restriction, and this is the one that I was just referring to, that people don't tend to like, because what we do with sleep restriction is we restrict the time in bed. So people with insomnia may sleep, the last person I saw was spending about 10 hours in bed and sleeping between 5 and 6 hours. In the sleep restriction protocol, what we did was we asked them to stay in bed only for the 5 hours that he actually spent sleeping. Of course, you have to explain the rationale for that, and I'll explain that to you. This can be tricky, and we'll talk more about that when it comes to the case study and the implementation of it. Stimulus control is another one. This one, again, evidence-based. We want to strengthen the association between the bed and the bedroom as a cue for sleep. So what we do here is we tell them to use the bed only for sleeping and for sexual activity. That if they are finding that it's been 15 to 20 minutes and they're not falling asleep, to get out of bed and do something else, so that we again strengthen that association. And then with cognitive restructuring, we address the thoughts and beliefs that we've identified, ideally by our questionnaire or our assessment, that the patient holds that are serving to maintain the insomnia. There are also relaxation strategies for those people who are tossing and turning, or who are highly anxious before they go to bed. And relaxation strategies are about equally effective. So whether you use a body scan or belly breathing, it doesn't matter, as long as they're doing some sort of a relaxation exercise. Those have been found to be effective in helping people sleep better. And then we also address sleep hygiene as necessary. So if there are any environmental issues, if their bedroom's too warm, that might contribute to their difficulty falling asleep. If they are drinking too much coffee, if they're exercising right before bed or not exercising at all, if they're eating late at night, we want to make sure that we address those. Next slide, please. So this here shows you how sleep restriction therapy works. And so you can see that this is over 8 sessions. And then that we have the person here is sleeping about 7 hours, but they're spending about 10 hours in bed. So what we do is we, since they're only sleeping seven hours, we're reducing the amount of time that they're allowed to be in bed to the 7 hours, which means that, of course, initially they're going to sleep less than 7 hours. But as the sleep drive becomes stronger and healthier, there's going to be more congruence between the time that they're spending in bed and the time they're actually sleeping. So this will maximize their sleep efficiency, which again, sleep efficiency is just calculated by dividing the amount of time that they're spending sleeping by the amount of time that they're spending in bed. So you can see that over time, after sessions 4, 5, 6, 7, and 8, the person is sleeping about the same, about 7 hours, and spending 7 hours in bed. And this is how sleep restriction therapy looks over time. Next slide, please. So this is an important way of explaining how sleep restriction works. So you see here the first line, the light gray boxes with the S on them represent how much of that time the person is spending sleeping, and the darker boxes with the W represent wakefulness. So you have your 8 to 10 hours there in the first line, and you can see this is typical for someone with insomnia. In the beginning, it might take them a little bit of time to fall asleep, and then they might say that they sleep, but then they wake up in the middle of the night and they spend some time awake. They sleep for another portion of the night, and then they may spend an hour or two awake. They sleep for maybe another hour, and then they spend all this time in bed and in the early morning trying to fall asleep, but they're unable to do that. So what we do is that we reduce their time in bed to the time that they're actually spending sleeping. And you'll see that over time, those periods of wakefulness become lesser in terms of duration. This serves to achieve what we call consolidated sleep, which allows for the person to go through the different stages of sleep so that they're getting really good quality restful sleep. So it allows the body to do what it does in terms of going through the non-REM and REM sleep stages like it's supposed to. And then once the person has achieved this increased sleep efficiency, we expand the time that they're spending in bed. And we do this slowly, so we don't tell them, okay, go back and spend your 10 hours in bed, but we increase the time by 15 minutes. And you can see that their sleep quality, the sleep efficiency is much improved. And that, they'll still have some awakenings. We'll wake up in the middle of the night to go to the bathroom, or, we may scan our environments and fall back asleep. And sometimes we don't even remember them. So the goal is not for them to not have any awakenings in the middle of the night, but to reduce the number of awakenings and the duration of those awakenings. And so the last portion there shows someone with better, more consolidated sleep. Next slide, please. And this one here is an example of what a sleep diary looks like. So we use this for assessment and also to keep track of their sleep efficiency and progress over time. So we ask our patients to tell us what time they go into bed and how long it takes them to fall asleep. So this is how we assess their sleep onset latency, how many times they woke up in the middle of the night, how long those awakenings lasted, what time their final awakening was, and if they woke up earlier than they desired. A lot of people say yes, and then how long, and then what time they actually got out of bed. We also asked them to rate the quality of the sleep and any comments that may be relevant to them that may have interfered with their sleep quality that day. So this gives us a lot of information in terms of the person's sleep quality, sleep efficiency, and their insomnia picture. And this is probably the most important aspect of Cbti for if they're engaging in sleep restriction. We want to make sure that we're tracking their sleep. So it is really important for them to fill out those diaries for assessment. Ideally, you have about 2 weeks, but one week might be fine. And then for ongoing treatment and progress tracking. Next slide, please. Stimulus control. Again, we want to promote conditioning of sleep to the sleep environment. So recommendations here are to go to bed only when they're sleepy, to get out of bed when they're unable to sleep, to avoid any sleep incompatible behaviors, so no tossing and turning, and to rise at a regular time, and to avoid daytime napping. So these are just pieces of information that you can share with your patients along with the rationale for them. And people tend to understand that once you explain it to them, and it's fairly easy to follow for most people. Next slide, please. Okay, the cognitive restructuring part, you may or may not have to do depending on the results of the dysfunctional beliefs about sleep questionnaire or what you're noticing about your patient. But some of the common problematic thoughts or beliefs about sleep include thinking that they won't be able to get back to sleep if they wake up in the middle of the night, or that they won't be able to function tomorrow if they don't get enough sleep. So we want to address those, and we might ask them, has there been a time in which you slept 6 hours and you were able to function well? The reason we want to address these problematic beliefs about sleep is because the more of these beliefs that the person holds, the more likely they'll be to engage in sleep effort, which, as we know, makes the insomnia worse. So ways to address this can include behavioral experiments, where we might have them sleep for 5 or 6 hours and see how they function that day. Coping cards, so reminders of the coping positive statements, saying, just because I slept for 6 hours doesn't mean that I won't have a good day. Sometimes I've had good days in the past, even though I got little sleep. Paradoxical intention has to do with prescribing the symptoms, so telling people to stay awake. It's sort of similar to the sleep restriction. People might not buy into it, but it's also a useful tool at times for people with insomnia. Next slide, please. And again, lastly, we have the relaxation and sleep hygiene. Like I said before, most of these procedures are equally effective, and some of the sleep hygiene strategies or recommendations include limiting caffeine, alcohol, or tobacco. So sometimes I've had people tell me that they wake up in the middle of the night and they drink a cup of decaf and they think that that's okay. There's still caffeine in decaf coffee. We want to make sure that they're exercising regularly. And in fact, there have been studies where we just have had people exercise and their sleep quality improves as a result of exercise alone. But of course, not right before bed, because then their physiology will be aroused and it'll make it hard to fall asleep. We want to ask them also to hide clocks in the bedroom, or to turn them over so they're not looking and stressing more about what time it is. And that the bedroom should be quiet, dark, and cool. The ideal temperature will vary per person, but we do want it to be more on the cool side. For me, it's for a lot of people, it's around 65 degrees. Next slide, please. And I wanted to give you some tools and resources. So there are treatment manuals that are available online that you can use, that will walk you through the assessment tools and tracking tools. They're relatively easy to use, and you can get supervision if needed. If you're really interested about sleep, there's this really good book I just read by a neuroscientist, sleep researcher, Matthew Walker. And it talks about, there's a chapter on Cbti for insomnia, medication, why we sleep, how we sleep, non-REM sleep, REM sleep. So if you want to make sure that you know what you're talking about when you talk to your patients in terms of sleep, that's a good and fun book to read. Next slide, please. And I wanted to be able to recommend electronic technologies. There are a number that are under development. There are some that are available through some organizations. I know that the Cbti Coach is an app that was developed by VA researchers that's free, that you can use as a tool with your patients if you're doing Cbti. Some of these other ones, you have to be, you have to pay for them, or you have to be part of a research study in order for you to be able to use them. So I wouldn't, you could look into them. I think at this point, unfortunately, they're not as widely accessible as I would want them to be, but definitely look into them if you're interested and you think your patients might benefit from them. Next slide, please. Okay, and then these are just examples of assessment tools that you can use. The Insomnia Severity Index, which was mentioned before, and then of course the depression and anxiety, PTSD assessment tools that you probably already use. Next slide, please. I'll end there. I just wanted to leave these slides over for your reference in case you wanted to talk about sleep problems during COVID. There are some practical recommendations in the article that I am presenting to you. And essentially, a lot of it has to do with what we just talked about. We want to make sure that we can prevent people from developing insomnia, full-blown chronic insomnia from insomnia that was associated with COVID. So with that, I will just advance the slides, and I'll pass it over so we can go over the case study and the more practical aspects of this. It looks like you're muted.
It looks like so. Is audio going there? Well, so Dr. Lombardero, thanks for going through that, and I'll just kind of. I know part of the segue that we're talking about is, and certainly, you know, in my own practice in primary care, I've kind of gone from, and we talked about this in some of the presenters chat leading up to today. You know, Cbti in general, there's multiple components, and sort of in its technical form, you know, there's some length to it, and so sometimes in primary care and also just in integrated environments in general, those of us who have been kind of more classically trained are sort of, we find ourselves in the situation of sort of wanting to maintain fidelity to that model and to that framework, and then also sort of meeting the structural sort of needs of our clinics, where we may be, you know, in very brief visits, or have, you know, perhaps even, you know, like 15 to 30-minute visits with folks if we're in a brief model, and not as many sessions. And so I know, you know, as Lee kind of hops in, we'll probably start talking about this a little bit more, but you know, that is, I think, where we find ourselves. And so there's a question of sort of like, how do we then begin adopting some of the, or sort of where do we draw the line between saying we're doing Cbti, and then also we're doing kind of a brief structured intervention. And so I think that's I'll actually, as we're waiting for Lee, I'll pose that to you, Dr. Lombardero. Is there, like, if I am, and I'll give you an example. I'll often take, when I have only a few minutes with someone, I'll take certain key elements of Cbti where it seems appropriate and deliver those to my patients. So, for example, certainly providing some education around sleep, but perhaps, you know, if they're the example you gave earlier, where there's a patient who's spending 10 hours in bed, but they're only sleeping for 5. I may select that as my target. Is that sort of like, in cases like that, like, do you have any suggestions for how I can make sure that I'm still sort of like maintaining the spirit of Cbti? Would you say that kind of thing is like a bad idea?
That's a really good question. So these components, there's enough research evidence for the sleep restriction component alone, and for the stimulus control component alone. So it's fine to use one of those if it's relevant to, and this is why the assessment piece is so important. If you're noticing that, you know, like we said, the person is spending 10 hours in bed, but only sleeping for 5, that would be a good indicator that they could benefit from sleep restriction. And also you want to do what the person is able and willing to do. So if, let's say that they're just not ready or willing to engage in sleep restriction, then I might choose stimulus control or even sleep hygiene, and see if one of those or both will improve their sleep quality. And sometimes it does. And in the perfect world, you would be doing Cbti as a multi-component modality in terms of your treatment option. But there's evidence for these also as being effective as behavioral treatments. So sleep restriction, stimulus control, and all of that.
Yeah, and that's good to hear. That's sort of refreshing to hear, because that is often, I found, you know, even when I only have time with my patients, those were sort of those two, the sleep restriction, the stimulus control, really the sort of the gold pieces. But then also the element of like figuring out, and I appreciate that you had mentioned that some of these things, particularly the sleep restriction, is a little bit painful. You know, it's the one where my patients would be like, I don't know if I could do that. You know, like, it's so contradictory to some of the ways that we're brought up just as human beings to sort of think of our sleep, like, you know, I need that time in bed, or like, you know, but I have to stay up and stay out of bed. What am I going to do all night long? And so sometimes I'd sort of find myself working them up to that, you know, where it'd be, okay, well, let's start with, you know, we'll take out caffeine from, you know, from the evenings. We'll, you know, we'll do some of the stimulus control. And then, you know, if that hasn't necessarily cured things, maybe then we'll sort of do the, you know, so, you know, I in sort of practice, sometimes it was like finding ways to sort of make the key principles work. But yeah, it took some time of actually practicing the full Cbti protocol with patients for a while before I felt really comfortable, like understanding the key elements and then applying them in that way.
Mm-hmm. Yes, and it's a really important point that you know, if the patient is not buying into the treatment, then it's not going to work. So you can have a perfect treatment protocol, but if the person's not on board, then you're not going to be successful. So asking, you know, where they're willing to meet with you. I mean, hopefully you're doing a good job at selling it, but you know, some of these components are hard to sell. If you're having someone come in with insomnia complaining, oh, I can't sleep, and you're telling them, okay, well, we'll reduce the amount of sleep that you're getting, because that just happens as a function of reducing the amount of time that they're spending in bed. They're going to look at you in unfavorable way. So you have to really explain it and make sure that they're buying into it. And you know, if they've tried a number of different things, and sometimes people will say, I'll try anything. I've tried everything else. But a lot of the time they would rather start with the other easier, sort of more accessible targets, and that's okay.
Yeah, exactly. Yeah, that was, I think in the point about kind of giving them the understanding of it, it's the conversations around CBTI, especially when folks are more, or maybe they've met with their primary care doc or a different type of provider and had been given more sort of sleep hygiene recommendations. Sometimes also my patients say, "Oh no, I've already tried all those things." I go, "Well, have you?" There's a couple key elements, and it's a fine distinction, I think. And people will often, and you started your presentation off commenting on this, will sort of swap those two and sort of consider, assume that CBTI basically is just, typical sleep hygiene tips, but there is that the measurement and then sort of like the careful intervention piece that I think is a little bit different. As we kind of, we'll see if Lee's able to join us, but I'm gonna pick up a couple. We had gotten a lot of questions from the audience, and so I may tag you some of these with you, but I'm curious. This question was specifically on how to get referred for CBTI. And specifically, they mentioned, like if you're mentioning it to your family physician, and I know we have some primary care physicians with us today, they may sometimes prescribe like a medication, for example, which I think, is fairly common. But if it is long-term, right, and those are the situations where we tend to see something like Ambien, for example, is not necessarily indicated. The question is, how do you sort of explain to the physician that this sort of therapy is indicated or required? I'm sure you've kind of had some experiences around that.
Yes. So as I said earlier, we now have sufficient evidence that CBTI is effective, that it's the recommended first line of treatment for insomnia. And this is not specific to insomnia, but we do have this gap between the research evidence and actual practice. And so the research in terms of CBT for insomnia is moving in the direction of implementation. It's taking some time, but this is one of the reasons I feel happy to share information about CBTI in medical settings, because the research shows that many physicians just are not aware that CBTI is the first line of treatment for insomnia, and they may recommend things like sleep hygiene, maybe thinking that it's the same, and it's not. So if you are working in an integrated care setting and you have the luxury of providing trainings, that would be ideal. There's also the possibility, if you're in an integrated care setting, to just provide a brief outline of CBT and what CBTI is. It can be a card that you develop yourself, explaining the different components of it, and just the fact that it is the recommended first line of treatment for insomnia. Yes.
That was, I found that too, once I explained to the docs and others that I worked with, kind of first, that this was actually like the aim is like you said, it's the gold standard intervention above any medication, and that it was something I could offer whether the patient was on medication or not on medication, like independent of all these different things, and that had these great success rates. It became the number one referral I would get from the PCPs was for insomnia. And so there's so much there. It's like, I find that most prescribing providers are not particularly happy to prescribe medications for sleep, in fact, because they know that it's often not the best answer. So they're, I think, very actually quite eager once they know there's a resource. And even if the person who asked the question, if you're not in an integrated setting, just like you said, Dr. Lombardero, even if you have sort of a card or a brochure, letting people in the community know that you can provide this service can be great. There's another question that came in. This is so key. Last year we did some, actually, and folks, if you go to our website, pcdc.org, can find it, some programming around chronic pain. And we know that especially, as we see sort of this higher incidence of pain in our population, it seems to interface a lot with sleep. Can you talk a bit about that?
Yes. So there's a chronic pain and PTSD, and we often see PTSD along with chronic pain, along with sleep problems. So then the question for many people is which one do we address? And there's evidence that if you address the sleep, Of course, ideally, the person is receiving treatment for chronic pain as well, and their cognitive and behavioral treatments for chronic pain. So you could even target both if you're in a pain practice. But if you improve the quality of the person's sleep, then there's evidence that their pain scores will improve. We also see evidence that among people with depression and anxiety, we see reductions in depression and anxiety scores for people who have gone through a Cbti treatment and are benefiting from sleep. So it is important to address the sleep. You do want to take into account the beauty of Cbti is that you're using cognitive behavioral therapy, which is you can use for the sleep, the pain, and the depression or anxiety too. So you could combine elements of all of those as it applies to improve the person's sleep.
Yeah, that's such a great point of like how these all fit together, right? So when we take a sort of that sort of a biopsychosocial approach to these things, like especially if you're already working with a client or a patient who kind of gets that framework, it's so much easier to sort of add this in. And I've even found there's some like just very sort of techniquey things, you know, it's sort of like I've noticed a lot of like my patients who have pain that tends to get worse when they're, you know, it's often like when they're laying still. So it's like sleep tends to be like they'll actually wake up in pain and that's interfering. And so sometimes negotiating a little bit where it's like, okay, maybe you're actually scheduling time to get up and stretch a little bit, you know, it tends to wake you up, you know, like if you use the sleep logs, like you described, you know, I noticed, hey, every day at 2 a.m. you're listing that you're getting out of bed, what's going on? They're like, oh, you know, my back is aching. I gotta, and so we've actually even, you know, scheduled in a structured sort of awakening there to sort of early intercept in the pain. And so there's like these ways that we can adapt it seems like for what's going on. Mm-hmm. There's a great question that came in, another one from the audience here. And they're really asking about, I think in general, the example here was folks with bipolar disorder, but I think generally, is there anyone who Cbti isn't appropriate for? Are there sort of like contraindications?
That is a really good question. Yes, for bipolar disorder, we do want to be careful with the sleep restriction aspect of it because we don't want to precipitate a manic episode. And also, you know, I would say, depending on the person's circumstances, I've had people say, you know, I'm traveling or I'm going to a wedding, or if they have an event or a reason that you identify as important in terms of you know, them not being able to adhere to the protocol, or if they do that engage in sleep restriction, for example, that might influence, let's say, that they're healthcare providers, and we don't want to deprive them of if they're not going to, you know, because we don't want to be responsible for medical errors. And we can work around that in terms of scheduling naps and things like that. Again, if they're driving and there are safety concerns, we do want to make sure that we're taking those factors into account.
Yeah, and that's a great point. And it looks like you joined us here. And so that's, I think the safety piece is often when, like, into that question we had earlier, like, how do you assess for this? Often that's one thing I find myself also asking about is, you know, are you already at a point where you feel like you're, you know, if you're driving, do you ever, like, are you dozing off? You know, when I had you out in the waiting room earlier, did you have a hard time keeping your head up? Because then we see, you know, are we concerned also about sleep apnea or other medical conditions? And that can certainly, you know, be one. Lee, are you, I'm checking if we're able to hear you.
I am so sorry.
We're really glad that we've got you back. So, you know, we've got about just under 10 minutes left in our office hour here, and I wonder if we could kind of pick back up. We started talking about some of the translation that I think you were getting into around taking these sort of core ideas and translating them into practice. So maybe you can talk a little bit about, you know, at FQHC at Henry J. Austin, how do you sort of like address this in that more kind of like primary care centric setting? Like what looks different for you?
So I think for us, I think one of the questions you may have already answered is how do we work with the doctors to not prescribe medications? Because we are integrated, we can go right directly to the docs and say, you know what, we would really like to do some behavioral health interventions first before we go to medications, and go through the behavioral health steps prior to having them initiate any type of medication. So working in that team aspect allows us the freedom and ability to intervene with the docs, to not go to the medication first. I mean, obviously, after they've ruled out any kind of medical problem and it is more of a behavioral health issue, then we're going to move into be able to go into the behavioral health interventions. The challenge is time. It's always time. And I believe you started to speak about that. So in our setting, it's always about time, and it's about the patient's willingness to return for the ongoing interventions.
How do you manage that part of it, particularly in terms of like getting people to return? And are you sort of choosing your targets in a particular way, or sort of knowing, I may only have, 1 or 2 visits with somebody? How do you approach that?
So basically, I think Dr. Lombardero brought it up, is we address the sleep hygiene first. We're really trying to go to the targets that the patient may be able to make a more immediate change with, to see if they have any impact or effect on them. Maybe allows them to feel some empowerment on being able to make those adjustments. And then once we do that, if there's improvement, great. If there's not improvements, then we're going to go more into the Cbti, and then have that discussion with the patient that this is going to be a longer term investment. They've made the changes that are within their capacity to change in their environment, and then go into talk to them about their willingness to participate in something that may be a little bit longer term that involves their regular commitment.
So I think we have talked a lot about COVID and the pandemic and sleep, certainly, but I can't help myself. And we've also got some folks in the chat who have asked about it, but have you seen kind of an increased demand for help with sleep, over this past, almost like a year now? Have the interventions looked any different? Have changed?
So for us, I think one of the things that I did want to bring up is in the FQHC setting, talking about sleep really helps with introductions to assess for other things that may be going on. It normalizes, it doesn't carry a stigma with it. A lot of people struggle with sleep, so it opens up a discussion, which allows us to go into more detail. As far as COVID is concerned, we're in an urban area. There's been a lot of unrest. There's a lot of concerns about safety in the environment. So there's a heightened awareness of what's going on. There's been challenges, obviously, with the ongoing change in government and a level of distrust. So there has been a heightened issue with sleep. There's been a heightened issue with anxiety. There's been a heightened issue with depression. People are isolated longer. So I don't think we've even begun to see the longer term effects of this pandemic at this point in time. So everything is just heightened given the pandemic.
Yeah, it's a pretty incredible time, but I love that point that you're making, that sleep is it's like something that we're all sort of like, I think most of us are sort of like happy to comment on, like, oh man, I'm exhausted today, I didn't get much rest. That and just it's been a kind of an exhausting time period, and so that it is sort of for many people kind of a safe topic. But then it does, right? It introduces so many of those other things. So what's like, when I sort of ask my patients, like, well, what's going on when you're not able to sleep? Well, suddenly now we kind of, there's that entrance into what they're thinking about, or what's going on in life at home, and their circumstances, social needs and other things. And nightmares, again, like tying it, I've often done sleep assessments where really what came up was that, the individual had gone through a trauma and was having experienced their symptoms related to their trauma, and that had not yet been addressed. But because sleep was something that sort of gave this entry, now we're able to say, okay, well, let's kind of talk about this, and then we'll also, be addressing your sleep. And there was actually a question specific about that. I'm curious if either of you have thoughts on of the interplay. And Dr. Lombardero, when we were talking about pain, you kind of alluded to this, like PTSD, post-traumatic stress disorder, and sleep. When people are having nightmares, when they're having that real hyperarousal that we see with these things, how do you kind of address that when they're being referred for Cbti or something similar?
If they are having nightmares and they're having these re-experiencing symptoms of PTSD, I would probably target the PTSD first if possible. If you have training in both, you can do both. But we do see that for a lot of people with PTSD, even once they've gone through some of the exposure therapies with prolonged exposure or Cbti, the difficulty with sleep tends to remain. So for many people, it makes sense to go ahead and go through the Cbti treatment after they've gone through PTSD treatment.
And so we have, we're down to just our last minute here. I'm gonna sneak in one more question here, and because we've gotten just a number of, and this just comes up a lot. What do you recommend for patients who are not necessarily doing well with worksheets or assignments? They're struggling with sleep logs. I certainly encountered this a lot. How do you address that?
I'll let Lee answer that, and then I'll.
Yeah, I think it's breaking down. For me, it would be actually to see if we can pick out the important parts where they might be able to come up with maybe some technology that they may be able to use, maybe some logs in the phone. How do we put those questions in the phone so that we can utilize it? Maybe engage another person in their life who may be able to help with it, because sometimes there's challenges with literacy. So it's just a matter of finding out where the bumps in the roads may be or the barriers may be to do something like that, and then work around it to come up with the information as best you can.
I completely agree with that. And if it's an issue of lack of motivation, then motivational interviewing tools can be really helpful too.
Great. So we're at the end of our time, and I think that and Jaime, if you could have asked us to the last slide there. The slides. A lot of folks have been asking about the slides. They will be the slides, and actually the full recording of today's discussion will be available at pcdc.org/sleep. In the slides, you have Dr. Lombardero and Lee's contact information as well, and they've generously agreed to make themselves available should you want to reach out. And again, we'd encourage you to check out our website, pcdc.org, for the full series. And Lee, that statement that you made of we'll sort of like work with them in terms of like what they're ready to do, and we'll make it work. Like that is the spirit of integration, and I think that's just a great way of putting it. There are so many structured approaches, and we need to respect the science and the research of it. And also, we're continuously, I think, working, especially in the integrated care space, to sort of match that with also then being on the cutting edge of the actual delivery of care and making these things align. And I think we're getting closer and closer, and conversations like this are hopefully bringing us to that place. So thank you, Dr. Lombardero. Thank you, Lee, for joining us again. Really appreciate having you here, both of you. And thank you to our, we got several hundred folks who have stuck with us, and really appreciate the conversation and the active chat. I know we did not have a chance to get to everyone's questions. We're happy to follow up, and we're going to continue this conversation. So again, you'll be joining us next time if you're registered, and if not, check out our website for a discussion around hearing actually from people who are living with different sleep-related conditions, then focusing on the medical and the physical health aspects of sleep. So stick with us. We've got a lot coming up. Thank you very much, everyone.
Thanks for having us.
Thank you.